Welcome, everyone. It's an absolute pleasure to welcome our ISPEC Talks guest today, Professor Sabina de Geest. Sabina is a professor of nursing at the Faculty of Medicine at the University of Basel in Switzerland and a part-time professor of nursing at KU Leuven in Belgium. She also holds adjunct positions at, ready for this everyone, Johns Hopkins University, the University of Pittsburgh, and NYU, New York University, reflecting her global leadership in health systems research. She leads the Pioneer Research Group, an interdisciplinary team focused on behavioral and psychosocial issues in people living with chronic illness. A core pillar of her work is implementation science methodology, particularly in the development of innovative, person-centered care models, often powered by e-health solutions. She's also a co-founder of the Swiss Implementation Science Network, IMPACT, which actually was a push for us to start ISPEC, which has become a leading force in advancing implementation capacity across the region. Sabina is a wealth of experience, insight, and global perspectives, and we're truly honored to have her with us today. Thank you for agreeing to this, Sabina.
The honor is absolutely with me.
Thank you. So let's start first with your path in implementation science, because you didn't start off as an implementation scientist, correct?
That's very correct indeed.
All right, so you hold appointments across several institutions and you lead an interdisciplinary research group. What drew you into this space and what consistently keeps you engaged?
So being a nurse, I have to say, being a researcher, having been working over decades in research, there comes a point where you ask yourself the question, what is the impact at the population level of what I've been doing? And you work in a space where you're being pushed in order to contribute to number of publications, fundings. And then there comes a phase in your career where you can start to think freely and where you also feel that you need new energies. And the energy became to really not work for impact factors anymore, but to create impact in real world settings. And that was a time where I was connected to Duke University, my dear colleague, Dr. Lea Zulich, and we started to teach a course together at the conference each year. And so this was kind of the natural path. I started to see, hey, there is a whole new research paradigm out there that kind of adds to the research pipeline where typically we stop. And we stop where we have our wonderful publication and we go for the next grant. But there is a whole next phase that also needs to have our attention because your research monies, which typically are public, they can't really come to fruition if there is not really the thought process of how can this evidence be relevant for clinical settings? How can we translate that in clinical settings? How can we make sure that we also do good science while we are looking at the translation? And so that is my part to implementation science. And honestly, it has been new energy. It has really been given a true push, and especially when we saw it works.
So what you mentioned, a lot of academics grapple with, right? The impact factors, the grants, and then they keep saying, okay, I'm just going to do this till I get tenure, until I'm, promoted to the top level possible, but then actually making the impact, which is what they want to do from the beginning, they can't necessarily do because the system doesn't support that, which is very frustrating.
Yes, but honestly, we have to see a system, is also reacting to the outside world. And what we see currently is that quite a number of funding agencies, just if I refer to Europe, the Horizon funding ask for impact. There is more and more the research groups who really reach out and ask, could you help with this implementation science part? Not knowing, they are kind of trialists, clinical trialists, but they start to understand there is something out there, and especially because funding agencies ask for it. At the same time, there is also in the academic environment, we see with the San Francisco guidelines, which kind of also say, we have to think broader about how to value and also to evaluate research performance. I also think in the UK, when you see that the evaluation of research is also more and more looking into, what is in the end, translated, or the impact, be it at policy level, be it in practice. So what we see is a movement within the research ecosystem, which has not yet fully come to development. But what I see is that, yes, we see clear indications that this part of translation is being taken seriously. Of course, translation has been a buzzword for a very long time when it came from basic science to from bench to bed. I mean, this is something that already was in the back of the mind. Clinical research infrastructures have been built. I mean, in Switzerland, for instance, we have huge amounts of money have been invested in clinical trial units, which have done absolutely excellent work in order to reduce research waste of poor clinical research. But there is a second type of research waste which has to do with, not translating, or, the well-described, only 40% ever is being implemented into practice. We even don't talk about sustainability. There is this huge log between, evidence generated and then implementation. 17 years, now there are some 15 years. No industry would ever survive. But it is also because the way that the system works still allows researchers to just work for impact factors and for, their own ego. For me, implementation science is a way to bring people together, people from research, but explicitly people who are in real world settings, bringing them together, having a good methodological approach, and then working together in order to get things implemented. And so our perspective is implementation science is not something that comes at the end of a research program. Implementation science is something that you already considered early on. And a very nice example is a colleague here at KU Leuven, who is bottom line a basic scientist, but he understands that his solution only can fly if it really can be implemented into clinical practice. So he invited to become part of a research program, which is still in the lab, but he thinks already about what will it mean the moment that we go live. And this type of people who have this paradigmatic approach of not only kind of basic science, not only pure clinical research, but also adding the implementation science piece, I think that will make the difference in the future. Plus, of course, I really look forward to ways that the academic system is starting to incorporate the impact in real world settings as something that you have to do before you get promotion.
Science and how, can you give us an example of using implementation science within complex chronic care?
Yes, absolutely. And so if we want to look at the impact of our work, we always have to think about the end. And the end is, are we able to influence population effects? So, for instance, one of the projects we are currently working on is a project in community healthcare, where we know that community dwelling, frail older adults, that's the group that get hospitalized. But a lot of these older persons are being hospitalized because their symptoms have not been early recognized, because there was not the chain of clinical reaction was too slow. So we are currently working on a project in which we are giving competencies to all people who are in contact with these older persons, not only the nurses, but also the cleaning personnel, also those who come into the house to do the cooking, so that they start to learn what is it that shows that these geriatric patients has these very atypical symptoms, and that then there can come a nurse in order to evaluate, if there is indeed an underlying cause. This is a project that is ongoing, but which is building on a successful program of research of my colleague Francesca Zuniga, who is working in a nursing home setting. And so she successfully adapted a program that was initially developed in the US for Swiss nursing homes, where they also did the same thing. They kind of added geriatric expertise, early science kind of picking up, having nurses in this nursing home being trained in order to do clinical assessments, to learn to communicate with the primary care physician, and they were able successfully to reduce avoidable hospitalizations, because you don't want to have these older persons in the hospital, because that's the place where they really kind of decline very rapidly. It was also cost effective, and now this whole program is being scaled up in Switzerland and is also evaluated. So this program, and this program is called, initially it was called Intercare, now it's called Interscale. What it shows is that you can take an intervention that is already been done, that showed to be effective. You can adapt it to another context, and you can build around it implementation science methodology in order to then not only be successful in evaluating and impacting your population outcomes, but also understanding why this is worked in this specific setting. So evaluating not only effectiveness, but also your implementation. And that makes implementation science so interesting, because you really go into yes, there is this element of quantitative evaluation, but you always add a goal to try to understand what is happening in the mechanics of the system. How is that the interaction between what is being done in the intervention, the context, and also the implementation strategies? And so this is an approach you can do over and over again. And within our institute, all the intervention programs we are currently doing is based on implementation science, because we as nurses, we have no right of existence as frontline workers if something does not change. So for me, it is a natural methodology for my profession to use.
You mentioned within this that the intervention was cost effective. And unfortunately, from what I see, and I'd like to hear, maybe you see different, we don't use enough cost effectiveness analyses within implementation science. And I think that so many of our interventions, if not all, but that's taking a leap, are potentially cost effective. And that's really what speaks to decision makers. Of course, everyone cares for patient safety and patient quality. But if in the end of the day, we can translate it to dollars and cents, there may be a bigger push.
I couldn't agree more. I couldn't agree more. And honestly, for me, health economic analysis is an inherent part if you do implementation science. The reason is you have always to think not only about doing this own project, but how this can convince policymakers, health insurers to pay it in the end. And this has to do with sustainability. So typically, when we start, we have our stakeholder group, and these policy people and the health insurers, they are part of the stakeholder group, and we ask them, what do you need as type of evidence in order to then afterwards pay for it? So an implementation science project, which is done without a health economic analysis, I mean, this is not in the spirit of what you want to achieve. If you want to achieve population effects, you want to make sure that there is an opportunity to have an intervention translated in the real world, having your evidence, strength of evidence concerning the intervention, but also the strength of evidence on the implementation strategies, and then having a cost effectiveness evaluation, not only from the intervention, but also the implementation strategies. So there is more and more health economists who join the teams and also the research space of implementation science. For instance, in University of Pennsylvania, there is Freya Nezir. There are others. If you look in the literature in the past years, we see clearly an increase in health economics analysis. And in addition to that specific methodology, what for me also is a methodology that is inherently part of implantation science is system science. Because we are working in complex systems, this is not linear. So we use, for the different phases of our project, more and more also system science to map context, to also understand, what is happening when we are going out there and we roll it out. So here you can't do it alone. Implantation science is team sport. You are really working in teams where a lot of people bring very important insights, not to forget people who are the end users, patients, families, clinicians. So it also kind of brings everybody together for the common goal. Implantation science takes more effort than doing an RCT. I always say it is like if you want to have a jumbo jet into the air, it takes you a very long runway. And it is like that. It takes you a long runway before you understand you have your stakeholder strategy, you have your contextual analysis to understand various facilitators, clinical workflows within a setting that will then inform your development of intervention, your development of implantation strategies, and only then you have your package together to start to do the implantation and evaluation. So typically an RCT starts and there is an intervention and they start, but then they might have a very nice result, but it kind of then falls like a pump flooding if the implantation has not been prepared. So the whole idea of implantation science has to do with having team members who are implantation science specialists who join other teams and inspire them. We see currently that pharma industry and biotech have gotten it, and there's a very easy reason. It's time to market, it's reach, because if they can implement faster, more successfully in a larger population, I mean, it's really kind of a clear business case. So here you see there are quite a number of spaces where this is now currently happening. What is crucial is that the rigorousness of the methods used need to be high. So I do see a need for using experimental designs, typically experimental designs in the later phases of an implantation science program, using cluster randomization, because an implantation is nearly always combined with impacting systems. And so what you see now in the past 5 years, a lot of newer designs have been suggested, very rigorous designs, and it also shows clearly that we see, New England Journal of Medicine, JAMA, Science, they all have editorials saying, we need to work on this. So my wish is that those who are doing graduate education, that they all get this basic methodological knowledge, as they also do statistic courses, as they do quantitative, qualitative courses, that they also have implantation science courses, because otherwise, if you do not educate, education is everything. You need to provide this mindset, and it's a different mindset than just being hardcore trialist.
I completely agree. Completely agree. So we're out of time, but I do have one final short question, and we'll end with this. You talked about these different methodologies. So looking forward, what are you most excited about? Is there a specific trend or area or methodological or clinical approach that you believe is really going to shape the future of implementation science?
I think it's the kind of combination, the very kind of well thought out combination of different methodologies with now health economics and also system science emerging. So we have Catherine de Coutre is a colleague of KU Leuven. She is working in the in translational science and is using system science methodology. She's an engineer. She's a system engineer doing absolutely cool work in Africa. So you see that this is something that is currently emerging, and we have to have this courage in order to go beyond what we feel comfortable with. So I just would like to invite you and all of your colleagues, please join us in Switzerland in February 2026, where we have our Swiss Implantation Science Network next conference, and we will talk about system science, we will talk about methods, we will talk about latest projects, and it is not Swiss anymore, it is really people from all over the world join. So we love to have you there.
Okay, so send us the link, and when we share the podcast, we will definitely share that invite.
Absolutely, with pleasure. Thank you so
Amazing.
much.
Thank you so
Absolutely,
much,
Ellen.
Sabina. It was great speaking to you.
Thank you.